transition to Dr. Manaker.
Okay. Thank you very much, Adele. As you can see, we're trying to speak quickly. The goal that the three of us had was to quickly get through our talks in about 15 to 20 minutes and then leave 15 or 20 minutes for what we hope is going to be some open discussion. For those of you who don't know me, it's nice to see some friends in the audience, but for those of you who don't know me, I'm Scott Manaker. I'm a pulmonary and critical care physician. I'm vice chair of medicine at the University of Pennsylvania. I do a lot of work, particularly on reimbursement, both representing the pulmonary and critical care community and a number of committees. I'm on our Medicare Contractor Advisory Committee. I'm a member of the CMS Hospital Outpatient Panel. It's a federal advisory commission to CMS on hospital payments. I sit on the RUC, the RVU Update Committee, convened by the AMA and all of our societies, making recommendations about the fee schedule, and I actually chair the practice expense subcommittee on the RUC. These are my disclaimers. They're reproduced in the materials for you. A couple of things I have already called your attention to, like my serving on the RUC and the CMS Hospital Outpatient Panel. I review records and do malpractice and disability work as well. All the consultancies to companies are actually more than 5 to 10 years old, but I list them there for completeness. Here's a quick overview of the topics that I'm going to be covering. Number one, we're going to be talking a little bit about administrative data and the failings of administrative data. Notwithstanding the failings of administrative data, as Adele just informed you, those administrative data are going to be forming the basis of all our payments, or many of our payments, going forward. I'm going to speak a little bit about public reporting. It will be a nice reminder of some of the things we heard at the opening session this morning. I'm going to then move into physician tiering and narrow networks. One of the conversations that we had in preparing for this was whether we should take a Medicare-only perspective. And my position was that we shouldn't, because how many of you have more than 50% of your revenue coming from Medicare? A minority. So the range for the pulmonary and critical care practices is somewhere in the range from 30 to 70% Medicare, and the rest are other payers. So by and large, to a greater or lesser degree, we need to understand some aspects of payment methodologies for those other payers. So I'll be speaking about that a little bit, and then emphasizing the proprietary grouper metrics which are out there, and I'll show you the website that you can go to see the CMS grouper methodology as well. With that as an introduction, let's start flying through the content. The clinical content in the records. I don't care if you're still writing paper notes in a portion or perhaps the majority of your clinical services. The clinical content does not actually create the corpus, the majority of the data. Most of the data that we are being judged on, we are being valued on, and we are increasingly being paid on is administrative in nature. And that administrative data is not just the E&M levels, whether it's a level 4 or 5 office visit, whether it's a critical care service or a subsequent hospital visit. It's not just the quality check boxes. It's lots of things like the morbidity and mortality, like the costs associated to that patient and attributed to you, or perhaps to the other individuals participating in that patient's care. It's whether or not someone somewhere did the right thing administering a flu shot or vaccination for Pneumovax, and I'll show you that data a little bit later on. And it's patient satisfaction. It's not only the HCAHPS scores, but it's things that patients are writing and blogging about you, not only on Healthgrades, as was mentioned in the opening session, but many of the payers actually have proprietary websites that their beneficiaries can go in and rate each one of you and me and Adele about whether or not we were a good doctor and a kind doctor and a trustworthy doctor. This is an example of data that I use to show two common problems with administrative data. Although the green box is obscuring the name of the physician, I'll tell you it's me. And this is standard data that we get from the University Health System Consortium. We get it every 6 months. It's handed out a rolling 2-year average every 6 months. And many hospitals use this for their OPPE and FPPE processes. Many health systems use it for credentialing and enrollment as well, as do we. And it's full of biases, so selection biases. Why do I say selection biases? I think there's about 40 cases attributed to me, and you can see that they're listed for major respiratory diagnoses. But for all the ICU time that I spend in the year, I see a whole hell of a lot more patients than 40. So why are only 40 showing up on my report? Anyone have an idea? It's because the attribution is based not on the name of the attending at admission, it's based on the name of the attending at discharge. So if you get better, we're going to send you out to the Florida hospitalist or one of the specialty services, and if you die, you're going to go on my record, or alternatively, if you're an asthmatic or a polydrug OD and we turn you around overnight and you're actually able to go home the next day, you might be attributed to me. But all those other patients that I'm taking care of, attributed to somebody else. And for the patient who's languishing in the ICU for 2 or 3 months and then finally passes away, only the final attending gets credit for everything that has transpired in the preceding 2 to 3 months until they died. The rest of us get a free ride for all of the quality metrics and all of the costs and all of the utilization. That's one aspect of selection bias. And you'll see one of the solutions is used in the grouper methodology. I'm going to show you some flaws of the various permutations for trying to solve issues about selection bias. The second is attribution bias. You'll notice there it's a couple of percutaneous gallbladder tubes and a couple of IVC filters. Now, many of you know I'm a very aggressive guy. I do a lot of invasive procedures, certainly in the older days before the residents now beat me to the bedside. But I'll tell you, in my entire career, I have never inserted an inferior vena cava filter, nor have I stuck anybody's gallbladder, at least not knowingly. That's attribution bias. It was some procedures done by the IR attendings, and somehow it got associated with my name. The errors in the data notwithstanding, these are the data that people will be using to rate us as physicians, our hospitals, our health systems, and to ultimately pay us. Just to emphasize the fact that the data are not necessarily accurate, this was a very well done study comparing the information in an electronic medical record that is then used to report the very quality measures in the PQRS and other harmonized metrics that Adele was referring to, things like cancer screening metrics. Did you get your colonoscopy, diabetes care, and the hemoglobin A1Cs? Did you send an LDL and so forth? And flu shots, pneumovax, and inhaled steroids for asthmatics. 3 metrics that we as pulmonary and critical care physicians are very interested in. And what they did was compare the electronic measurements about whether or not these quality metrics were fulfilled to a manual review of the chart, looking at the pieces of paper that were scanned in, actually reading the progress notes where the prose says, Mrs. Smith got her flu shot at Walmart or from her PCP. But since it's not ordered in the record and it's not entered in the immunization activity, and there's no electronic way to find it, unless you're actually reading the chart and combing through it, you'd completely miss it. That allows you to figure out what are the false negatives, what are the false positives, calculate the sensitivity, calculate the specificity, because there's a lot of false positives and there's a lot of false negatives. And when you do that, you can see that there are statistically significant shortfalls in the number of patients who would receive credit for actually receiving their inhaled steroids, because if the primary care provider prescribed it and we didn't, or we didn't update the electronic medication list, as so many of my colleagues do, we wouldn't get credit for it. Same true for pneumovax. Again, a statistically significant difference in what you can find combing through the chart compared to what is electronically being measured, and ultimately we are being paid. Do any of you ever go trolling through HospitalCompare and see how your hospital measures up? Now, I'm from the University of Pennsylvania, Penn Medicine, and we're in a very competitive environment in Philadelphia. We've got the Temple Health System, we have the Jefferson Health System, we have the Drexel University Tenet Hospital system. Across the river is Cooper. It's a very competitive environment. So a couple of years ago, I went to HospitalCompare, and I took a look. How are we doing? HospitalCompare is very crude metrics. Top quarter, bottom quarter, middle 50%, and we are solidly mediocre. Unfortunately, the other couple of places that I tried comparing us to are also solidly mediocre. So very difficult to get administrative data that is discerning of what we would a priori think about as quality. You'd think 3 major academic institutions, at least one of them should be in the top quarter. Are the data meaningful? Following up the theme of the top quarter versus the bottom quarter, here's a very well done study of the Medicare database, looking and comparing the hospitals in the top quarter for quality metrics, for performance measures on acute MIs, heart failure, and pneumonia, and comparing those best hospitals to the worst hospitals, asking the important outcome question, not whether the electronic click box was checked, not whether the patient liked their doctor, but did the patient survive? Did they die or not? A hard outcome. During the hospitalization, 30 days out in 1 year. And what you can see is the hospitals in the best quarter compared to the worst quarter had a 0.8% absolute improvement in the risk, in the likelihood of survival, in their relative risk for surviving from an MI during that acute hospitalization. That's it. Top quarter to bottom quarter, 0.8%, and it extended through the year. Similarly, a 1.4% likelihood of survival benefit for patients with pneumonia, but paradoxically, the best hospitals seem to do worse for heart failure. And the authors of this article pointed out that the performance measures that are out there are clearly not tightly linked to hard patient outcomes. Nonetheless, that's how we are being measured and how we are being judged. Now, one of our colleagues came to me at this meeting a couple of years ago and said, my friend in a certain part of the country is in the hospital with belly pain and has diverticulitis, and they think she needs an operation. And they recommended this colorectal surgeon. Do you know him? I said, never heard of the guy. It's a little tiny town in a certain state. Let's look him up. So he's the fellow on the left. And most of the time, the patients say, well, you know, we're not really sure if he understands us. We're not really sure he spends the right amount of time with us. We're not really sure he's listening or paying attention. And so I said, let's take a look in this geographic area, colorectal surgery, let's see if we can find somebody else. Well, they had much better ratings. Now, I would ask you, which one of these two physicians would you prefer taking you to the OR to repair your diverticular abscess? Right. Now, why public reporting, which I will remind all of you started in the early 1990s in New York, trying to improve outcomes from coronary bypass surgery among different surgeons and different hospitals. The notion, the idea was it would inform patients, referring physicians, hospital systems, who the best providers were. You'd preferentially select the best providers, and you'd stimulate physicians and hospitals to compete. But the adverse consequences of that are both cherry picking, finding the easiest cases to get good outcomes, and lemon dropping. Let's forget about the real tough ones so that they don't have an adverse effect on our statistics. Some people will achieve the metrics regarding of the applicability. Let's send that 85-year-old patient for their colorectal screening with a colonoscopy, even though it is not clinically indicated because we're trying to improve our performance. And it completely discounts the notions of patient preference and physician judgment, that for the patient who doesn't want a colonoscopy under any circumstances, you don't want to order a colonoscopy. All right, I'm going to move now and talk a little bit about tiered commercial products. I'm just going to show you a couple of web shots to give you a flavor for this. Two we're going to focus on, the Excel and the Cigna program. So Aetna has a program called Excel. Are any of you familiar with this program? It's present in like 30 or 40 of the major metropolitan markets across the United States. Well, they make no bones about it. They talk about cost efficiency. And if you have a good cost efficiency, I'm saying cost efficiency, I want you to hear cheap. Cheap. Low expense. Then you'll be in the preferred network, and patients will have a lower copay. Here's the website for Cigna. I couldn't get on it because I don't have Cigna insurance. They limit the website only to Cigna representatives. Same thing, though. Here's Independence Blue Cross in Philadelphia. They sent this letter to me and to every one of the 2,500 physicians in the largest of our several practice plans, saying, we're rolling out this network of quality and cost and quality transparency tools. And I blow it up for you here a little bit. The transparency tools for participating specialists, patients are being encouraged to write physician reviews, and then members can read those physician reviews. They're collecting the data and then providing that to beneficiaries so they go and make informed decisions about who they want to talk to, who they want to go see and get their health care from. And Tandem is a national company that has invested with Independence Blue Cross in the Philadelphia market to buy 250 to 300 primary care practices. They are providing those primary care practices with exactly the kind of data that we're talking about now. How do these companies come up with the cost efficiency data? It's the same metrics for those episodes of care or grouper methodologies that Adele mentioned was in the CMS cost methodology for the value-based modifier that they're forswearing for 2017, but will be proceeding in 2018. They take the claims data, they take the data and attribute it to individual doctors, and then they profile the doctors. There's 3 different commercially available ones. They take the diagnosis codes, they take the procedural codes, they take the drugs, and then they put them into episode treatment groupers. These episodes, just like this. So what you can see here is Grandma took a fall in the kitchen and she broke her hip. She went to the emergency department, she had her hip fixed, she dropped a couple of units of blood in her thigh, so she had an iron deficient anemia for a couple of months afterward. And they said, we're looking at these claims, and there's an anchor claim in that upper one where she went to the office visit and the femur fracture was detected. And we found all of these other claims in the system, and we can find one at the end that's clearly linked to this office visit. But there's a bunch of claims here in the middle that may or may not be linked to the office visit. And what's this nutritional deficiency? Well, it's her iron deficiency anemia. And they say, you know, we only have 6 claims here, but if we create a second episode, so we have one for the hip fracture, and then we have femur fracture, and then we have one for the anemia. Looky here in the lower one. Now we can get a whole lot more claims in, and we can run these 2 episodes, and we can attribute one to the physician taking care of the femur fracture, and the other episode to the physician taking care of the iron deficient anemia. So we'll have more data and more episodes and a more robust measurement of our physicians. Well, this was actually piloted. We're here in 2016. This has been going on for a decade. People have been working on this. And I'm going to show you the data from some of the information presented to MedPAC, the Physician Advisory Committee to the Medicare program, showing that you could group 85% of the claims. They looked at 150 million Medicare claims for 35,000 physicians. That's just a subset of the data available to them because they didn't want the computers running all the time. And they were able to group 85% of the claims, accounting for 96% of the dollars, into 6 million episodes. And what was interesting is there was just under 1,000 outlier physicians among 25,000. And 90% of those outliers continued to be outliers in the following years. Now, this is what the data looked like. These are the cheap, inexpensive physicians. These are the very expensive physicians. You don't want to be one of these doctors in the tail who cost a fortune, right? And what do? Because they need to do statistics. They did a log transformation to normalize the data, and you get this beautiful bell curve, but you still don't want to be out here in the tail. Here's thousands and thousands of cardiologists in 6 major metropolitan areas. And they just ranked them from the cheapest to the most expensive. Cheapest to most expensive. Don't kid yourselves that there's any statistically significant difference from one doctor to the next one, but that does not prevent Medicare or all of the other payers from saying, you outliers here in the tail where the red bars are outside the confidence interval, you're outside of the network. You're outside of our narrow network. We're going to have a very high copay to dissuade patients from coming to see you. The different grouper methodologies that are out there come up with slightly different results. They're very similar, but they can be slightly different. You can see, even though there's 13 claims here for the episode of the hip fracture, compared to 8 claims with this methodology, the dollars that are accounted are largely the same. Sometimes you'll get an episode here for Alzheimer's that will be very different, thousands and thousands of dollars difference from one here for other psychoses. 2 different methods, you get 2 different answers. I'm not saying either one is right, they're just different. What are the consequences of those different methods? So here's a very nice paper taking all the Medicare data from the state of Massachusetts and pooling it with an all-payer private database for all the patients in Massachusetts, which was available when they went to a single-payer system because they had all the data. And you could take those episodes and assign the cost to a physician based on the plurality of their costs. So if a single physician had 35% and all the other doctors were less than 35%, that's a plurality. Assign it to them. Or you could say we're not going to assign that one to any physician because we're only going to assign it for the majority of the professional costs. And then you go through the different algorithms, plurality or majority for E&M visits or total costs. Do you do it by patient or do you do it by episodes? There's 12 different ways you can do the attributions. And the critical thing here is using the combination of Medicare and the all-payer claims database. They had thousands and thousands of episodes that could be assigned to a physician. Thousands. So even though you're practicing, you might not do much hospital work, that does not prevent the method from nonetheless assigning you thousands and thousands of episodes that you're participating in their care. COPD, pneumonia, asthma, all for you. This compares the physicians in the top 20% to the bottom 20% for the available quality metrics. And depending which of these 12 methods you use to attribute the episodes, you've got 20 to 60% likelihood of moving from the top to the bottom. The purpose here is to just inform you, these are the metrics, these are how they're being applied, and when you're trying to decide, am I going to go in an ACO or am I going in with some contract with my private payer, I need to be on a level playing field. I need to at least ask the question, how am I being judged? How are patients being attributed to me? As you can imagine, one of the reasons we're not participating in an ACO at our health system is because with those other 4 academic health systems in the city, plus a lot of other private hospitals, we have no control over the extent to which patients will seek emergency room care at that competing place and go see a primary care or a specialist physician over at that place in addition to seeing us. And there's no prospective way for us to know who's in and who's out of the patient population being attributed to us. Last couple of slides so we can keep this moving and on time. Consumers' access to healthcare. This was in the New England Journal a couple of years ago. It was written by Mark Kelly, who many of you may know. And it was just showing that, in general, patients are starting to ask more and more data and more questions about their physicians and looking for that information on the internet. Just last week, I heard a presentation in our institution at Penn Medicine. Currently, 20 to 40% of all of our patients are going to the internet, looking at health grades, at other metrics, other information about us, printing information off our websites before they ever come through the door for the first visit. The CMS grouper methodology for the value-based modifier is on the website. This is the site here. What I'll do is I'll create a handout and upload that to the website so everybody will have the slides. You'll be able to get this information. It was slated for the January 1, 2017 payments. Fortunately, Medicare is holding off. And I'm going to stop right there. Just remind everybody that we do have a coding book that reminds you all of the basic information about evaluation and management codes, bronchoscopy, pulmonary function testing, in addition to some of these new topics for 2016. The old book, we didn't reproduce all the unchanged chapters on revenue cycle and so forth. And we're going to hold questions for the end because Adele is going to rip through Sharon's slides right now so we can hopefully set up a very robust discussion.